And with that, I'm going to welcome our keynote, Sanjay Doddamani. A little bit of a bio on him. He's the Chief Executive Officer at UpStream, which is a global risk organization with a unique model of integrated team-based care, clinical and retail pharmacy programs, and two-sided risk-bearing capabilities for primary care physicians to be successful in value-based care. Before that, and where I've got to know him, he was the Chief Physician Executive and COO for Southwestern's Accountable Care Network. Before that, he was an executive with CMMI, the Innovation Center, and before that, and this is actually where I met him, was Chief Medical Officer at Geisinger at Home. Anyway, so excited to have him. I know he's got an amazing talk. Welcome, Sanjay.
I think it's on. Perfect. Okay, wonderful. Good morning, everyone. You know what? Let's give Nicole another round of applause. So Nicole is right. I first met her about 6 years ago and discovered the amazing activities that FLAACOs was doing. And I understand that membership has grown, and it's great to be back in person. I think it's, second year that you guys have been back. So I feel very honored to come here, especially because there's such a plethora of physicians, provider community is so active in Florida related to ACO movement. And you've got an incredible list of sponsors that have come and continue to support these activities. It just can't be done any longer without that level of support. So really wonderful to be part of this. So as I think about where the industry is going and how relevant to make this discussion to you, I almost think of also my personal journey in this. By the way, is it too loud? Is there feedback, or do we need? No, we're good? Okay. I personally don't have any disclosures or industry relationships or sponsorships for talks and things like that. We do have partnerships with entities across multiple disciplines, whether it's AI, data analytics, and other areas of support to patients, especially in the homes and things like that. And so that continues. So this is a really important time and an inflection point in the history, I think, of the Medicare program. We've got the aging baby boomers who continue to add 10,000 beneficiaries to the trust fund every day. We have more and more patients switching to Medicare Advantage, understandably, because they've been traditionally more resource rich and far greater flexibilities. We also have and recognize that CMMI in October of last year came out and said that by 2030, that all payments in primary care need to be value-based. That's a very tall order. There are others who argued that that's pretty far off. We need to be accelerating the movement. And yet there's this 2 feet in one in each canoe, living in value-based care and then fee-for-service. And how do we reconcile this to make it very relevant? And that's what most physicians continue to struggle with in primary care. And we've seen so much of market movement, whether it's hospital consolidation, acquisition of practices, the big pharma, Amazon, all entering the healthcare landscape. And the shift from volume to value is also associated with the recognition that primary care only receives 5% of the total Medicare spend. And there's such an importance related to high-income countries who put in 15, 18% of their healthcare dollars into primary care. And so how do we play that catch-up? Is it worth continuing to look at the MedPAC recommendations for investing more dollars into primary care on a fee-for-service chassis? Or should we now completely adopt a total cost of care model? And how can we make this less risky for primary care physicians to adopt a full cost or full financial risk model within which to participate? So we see now this open up in traditional Medicare. Firstly, I'm so glad to see the data that was put up by David and that Nicole presented, because Florida has done exceptionally well. You know, the benchmarks are high, but the performance has been exceptional. And there are a few, key beacons out there. I know there were 2 names of ACOs that were listed on the slide. But, we continue to look south when we look at, innovation because of, I think, the adoption and embracing of the ACO movement here. And over $1.5 billion has been saved through the MSSP program. So I think it's a very important program, but where do we go from here and how do we accelerate that movement? And so with the now rebranded ACO REACH, there's opportunity, I think, for the remainder of the Medicare population, the other 55%, so to speak, to actually be, I think, tapped into. And that total addressable market is 64 million lives. And so when I look at, I'm told, about competition, it's one of the best things, because I think all told, even if you were to include Optum and others in the Medicare space, we're talking about, 1/10 that in terms of the total, support for Medicare beneficiaries in some form of a value-based construct. So we really have so much work to do to go from 5.5–6 million to 64 million to help accelerate that pace of progress. One of the most beautiful things to me is that primary care physicians recognize this. They express burnout. They express that at some point they have considered selling their practices. It's not just for the lucrative dollars. I think why they came into this was the right reasons. But with the ever onerous requirements from a regulatory standpoint, from a reporting standpoint, from a quality participation standpoint, from having to participate in these models with all their inherent requirements, it's also become very expensive. And so how does this get reconciled? And at the same time, we see that patients love their PCPs. There's a less than 4% churn with primary care physicians, unlike with other specialties. So I think it's a really great confluence of issues that can find a solution and is already doing that. And yet, the broader infrastructure in primary care has been steadily crumbling. And it doesn't look like when we talk about the select group of ACOs that continue to tap into the resources. But when you look at the broader landscape, there are actually fewer primary care physicians. And that is very concerning. It's very concerning at the National Academy of Science, where they report out what needs to change in terms of paying for primary care physicians, for teams rather, to take care of patients, to drive this high quality care models, at the community level, training of folks. I think all of these they recognize will reduce that risk of burnout, and to have the right information technology, not just the interoperability, but also the access to data, how this is even provided to physicians, how much of this has to be paid for, and to continue to shape the innovation, but somewhat unbox the black box so that there's more data sharing, especially of risk stratification and other components that are AI driven. And ultimately, it's all to do with the implementation of these programs to drive the high quality care. So if we were to do all of this, it would take 27 hours a day. There was a consortium with the University of Chicago, I think Hopkins participated, others, that's came out in the summer of this year saying that it would take 27 hours a day to achieve all of those things that you need to do to keep patients well and out of hospitals. And that's simply untenable for anyone to even think about. The breakdown of that is that a large part of this work is preventive care. And we know that while this could be architected and overseen by primary care physicians, you do not need the PCP themselves to be, I think, managing every aspect of that preventive care. And that's where the team-based approach, I think, is a highly scalable one when you look at taking on more and more lives into a panel and really driving and shifting the incentives. I did go out, I think it was about maybe 10, 12 months ago, to meet a group of doctors in Charlotte in North Carolina. And there were two things that I took home with me. One one of the physicians said, "I'm tired of maybe money." And that kind of stuck with me as I was thinking about how we design a model that pays in a more concurrent basis. But that concept of having to wait and yet having to put out is very troubling. You don't see this in other disciplines. You don't see this in the legal profession. You don't see this in the retail industry. You pay, and you get paid concurrently. The second component, or second thing that was brought up there was that, they just keep getting more and more tasks, more and more requirements, and how to get through that. So this team-based approach, I think, is very necessary. And when you look at, the average commercial patient, which reimburses really well on a fee-for-service basis, and when you look at the traditional Medicare patient, it's understandable that primary care physicians have to balance their panel in order to pay their bills. So how do we make Medicare on par with that in terms of creating the opportunity? To me, that is not only driving more dollars in, but having to sort of reconcile that savings, if you like, in real time as to the real potential. Because then you can actually open up access. And one of the most critical things I think we face today for seniors is access. We saw that during the pandemic. They struggled tremendously for how they were going to be cared for. Telemedicine emerged and now is here to stay. At least, that's, I think, a consensus now more broadly across the federal government as well. But in terms of true access to care is anticipatory, right? And caring for patients who are living with multiple chronic conditions. And so managing acute care is the smaller, task in the whole thing. But, that's traditionally the basis on why patients come to see their doctors, is when they're not feeling well. And so I think shifting that more upstream, going towards, the preventive care aspects, but having, in a way, having that emanate from the primary care physician's practice is, I think, the ultimate goal, where you can balance out the time spent and the return on that investment. Another interesting thing, if you go 10 miles from where we are here today, you can drop 9 years in life expectancy. So to me, this area deprivation index and bringing this into the fold, and we heard about, I think last night there was, you guys heard on social determinants, and when we look at supporting health equity in a far bigger way, this has to now become mainstream, and it needs to be paid for, whether it's food insecurity, medical transportation, I think even recognition of vulnerable populations and with touch points, with access. For years, we've heard that coordination of care is really important. CCM has been very underutilized in terms of billing, but at the same time, the more frequent touch points patients have, the improved access to care, especially for the right patients who are struggling. So this number sticks with me, that you can travel 9 miles or 10 miles and drop your life expectancy by 9 years. In my own personal journey, it was very accidental. Nicole kind of gave you a little bit of summary of my recent sort of employment, but I was a cardiologist, sitting in a dark room, reading echoes, taking care of patients with heart failure, and took on an administrative job at a public hospital in New York. And one of the biggest things we saw was a lot of patients were not showing for their appointments. So a huge no-show list. And at the same time, there was a backed up waiting list for months. And so we actually decided to take everybody with two or more no-shows and tell them they don't need an appointment again, and rather give them sort of a unique system within which they could just come in and be seen in an open access clinic. And that open access clinic actually started as the foundation for me about a team-based approach, because it wasn't a physician who saw the patient. Think of Walmart and a greeter. It was a nursing aide. And then they would quickly get the patient over to be sort of assessed in terms of triage by a nurse, and then determined to be, whether they were needed to be seen first medically or socially, or whether it was an insurance issue or medication issue that needed to be solved. And that open access clinic actually created a tremendous, I think, ripples in terms of reducing hospitalizations for people who were living with chronic conditions, fewer visits to the ER for ambulatory sensitive conditions. And so that's kind of what took my work from a single hospital into an integrated care delivery system, where I started to focus on the clinical models themselves. So Nicole mentioned a home-based program. I co-founded Geisinger at Home. The home-based program to me was that 5% of the patients were approaching 40–50% of all healthcare costs. And those costs were mainly related to their chronic conditions, multiple chronic conditions. And again, poor access. So these highly dependent patients were circling between hospital, nursing home, and weren't getting in to be seen by the primary care physician. In fact, there were many patients in the program who for many months had not even been in touch with their PCP. So the medications that their PCPs had listed and what they were actually on were totally discrepant. And having that kind of access in more real time and connecting that back into the primary care physician's office was a very attractive proposition that could actually, I think, address the whole person in a better way. But what was lacking to me was the important focus on how are we going to pay for all this care. In the case of the previous model I described, we got funded by an MA plan, we got funded by a health system to help support that activity. So working in CMMI gave me, I think, a recognition that from an alternative payment model standpoint, from advancing primary care and from Medicare's investments into primary care is now here to stay. We see this through several, I think there are 4 or 5 different models: Independence at Home, the rebranded ACO REACH program, Primary Care First, and this continued evolution to support primary care. But we haven't, as a nation, captured this fully. We see more and more practices adopting some form of an ACO, but it's really been in these early tracks of MSSP. And so how do we keep that moving while continuing to support primary care physicians and reducing the risk to the practices? So that's where I came into this phase of my career, which is to sort of bring this all under one umbrella, delivering the care model into primary care practices, participating in a full risk total cost of care model, agnostic to whether it's Medicare or Medicare Advantage, so that we could, I think, focus on seniors in a better way. But the other part to this is, of course, technology. Huge needs in terms of risk stratification, in terms of consolidating the care plans, in terms of advanced analytics, for use of these programs. So this is where we have started to play a lot. We see others also innovating in this space. You have Allidaid participating in this conference from a sponsorship, but others too. And I'm actually very glad and heartened to see that there is now continued growth and there's a tremendous explosion of support for primary care. It's hard to sift through, where we're ultimately going to land and how this, becomes much more standardized in terms of, adoption and widespread adoption. But having an innovative payment system so that physicians can get paid in more real time or on a more concurrent basis, and really, on some foundation of metrics that, whether they're quality, utilization, any number of metrics, also those that I think incorporate social determinants and health equity are really important so that we don't leave patients behind, especially the duals population and others who are struggling. So this is, very encouraging. How do we now capture this into real time for practices? There are 110 provisionally accepted ACO REACH entities, but there's been uncertainty on whether this program is going to continue, what's it going to look like, and there's concerns about the implications for big pharma and private equity and others coming to participate in traditionally what has been hospital-sponsored community activities to put programs up. But on the flip side, the individuals and the group primary care practices have done exceptionally well. As I mentioned, and Nicole also attested to that, over $230 million saved in Florida on MSSP and $1.5 billion on a federal level. It's a really, really encouraging, that I think should at least have us all recognize that not only is the ACO movement here to stay, it needs to be further supported. And if we can do that in total cost of care, then greater dollars can be shifted into primary care, and we can then achieve the 10% goal in terms of primary care dollars spent. So 2023 is going to be a great year because many Medicare Advantage plans have started to include things like home modification, shower rail, egress, lighting, things that you can support, companionship for patients, food insecurity in a more broader way. And then there are so many regulatory flexibilities, including beneficiary enhancement through ACO REACH, but also I think in MSSP enhanced opportunities to support patients from a health equity standpoint. So to me, this I think holds great promise. There are over $200 billion in health equity in terms of placing the value of eliminating these disparities. And we need to move this into a business model that's a much more collaborative model. I'm not able to see how any individual practices can take on all of this and continue to see patients across all business lines. So partnerships, I think, are really important, even for hospitals. Many of them have recognized that they just would spend so much of their overhead and have far little savings to be able to achieve their goals without finding the right partner. And we also recognize that the opportunities need to continue, especially around data sharing to address health equity. So I'm going to conclude by saying that we all recognize the shift from the primary care physician being a cost center and in fee-for-service to really being the architects or the quarterbacks of healthcare, the healthcare system is not only within reach. I think it is going to be the future of healthcare, and that's why you track the dollars and where the investments are going, especially on the private and public funding side, is towards having a better primary care. So think of those 9 years and how we can give those 9 years back to patients. Happy to address any questions. Thank you so much for having me here today.
Anybody have questions for Sanjay?
That's said a lot, but it was on a very understandable level. And I always like focusing on the primary care delivery system. And, I agree, when you talk about access, it's not just access, but it's reliable access. It's, we see some offices that just, you can't talk to them. And there is no system to filter out. And I like that idea of having an open system where certain people can actually access healthcare when they need it. And there is a lot of them that need that. But how do you not provide inequity by allowing some people to walk in and some people to be scheduled? Because eventually it looks like, in my opinion, there'll be many more people walking in for a visit than getting scheduled. Are we talking about changing the whole model to just people coming in when they feel like it?
It's a great question. I apologize for not having the right data to be able to talk about this, but just anecdotally from the practice, far more people had the opportunity to have open access than those who actually showed up. The good part is that they started to at least connect in terms of their needs, saying, oh no, I don't want to come in, but I am running low on this medication, or I just want to talk to the doctor. And then, they're actually ended up being fine to start off by talking to a nurse. And then, based on need and based on the recognition that, the issue needed either reassurance or needed, a change in approach, that this interdisciplinary team could get into action and then, when needed, to have the physician participate in this. But so much of this work was then divided across, the licensed and non-licensed team, that, the yellow pill last month, is actually the white pill this month, doesn't need the physician. It actually needed somebody like pharmacy tech or someone else to be able to just, track that and make sure that it was just a switch from a brand to a generic that, caused that color change. And so, just providing that level of reassurance, I think solved so many things that, I think it's more the fear that everybody's going to show up and they're all going to show up on the same day, rather than actually, that need. And I think patients, just having that security that they, know they can come in, they tend to actually come in sooner. They don't tend to wait till the very last, especially when, you create this opportunity that, you're not turning people away or saying that, we can't see you today, go to an urgent care clinic with, again, anxiety. Managing anxiety in patients who are living with chronic conditions, I think, is so important. I saw this with patients who had heart failure, but also other chronic conditions, where, especially with COPD. So, and then there's a patient, group that just, they're not able to come in for any number of reasons. And they're so dependent that addressing that at the health equity level in tandem with this, I think is the way to approach it. It's a great point.
I think someone already had the mic.
Yes, hi. I have a question. As we start to shift over to addressing health equity and the social determinants of health, how do we capture data? There was comments about Z codes and different types of ways to identify it, because in order to structurally address it, you showed the, the deprivation area index mapping, but how do we bring that into a patient level to really be able to track it, to determine what's needed across looking at registries and building that?
I'm really heartened to see that, firstly, everybody hear the question on things like area deprivation index. How does it come into the mainstream, data analytics platforms and even the EMR in terms of knowing, a patient's risks? I'm really heartened to see that now many of these analytics platforms are actually incorporating those social determinants into the platform. We use an AI risk stratification engine that actually has zip codes and other economic information and some open access information that is driven into this. But we're going to continue to see evolution on this front. There are some simple screening that I think are important, that you can do with patients, and the ACOs, that you participate with also, can provide you with that level of data. So, advancing age to me, especially very frail patients. So, frailty, advanced age, the presence of multiple chronic conditions, even the presence of polypharmacy, 10 plus, 12 plus medications, and the ability to ambulate, the use of DME equipment, in other words, a walker, history of falls, history of repeated hospitalizations, ED utilization. Those are some of the ones that we look at. We actually have a group of measures called the Elite 8 that we use to kind of track some of these. But those are kind of some of the surrogates for where there's also poor access.
Yeah, thank you so much for that really informative talk. I just have two quick questions. One, when I looked at your motto, having pharmacist-led clinical teams, and my initial thought was, yeah, because they manage the medication, drug interactions, that kind of things. Are there other benefits for having the pharmacist sort of lead the team? That was one question. And then the second one was around the community partnerships. Where do you see the need and the opportunity in those areas?
Great questions. And the second part of that question was on community partnerships, and where do I see
The need and the opportunities, where do you see that evolving to?
Okay, it's a great question. So we have a pharmacist-led model. When we, partner with a practice, we have a pharmacist who's, sort of been through 4 years of pharmacy school. Many of them have actually even done a fellowship. And when they come to us for training, we actually focus on training them for behavioral psychology, forensic listening, patient engagement, and more broadly on coordination of care. When they sit down with patients, they use rudimentary tools like a piece of paper and a marker, moving bottles around for an indication for a medication and a medication for an indication, and then finding those orphans that can be put to the side and having to go over each one of them, not just for prescribing, but for also de-prescribing. But the broader thing is collaborative care, right? So working very closely with the primary care physician. And so our pharmacist's first obligation is to the practice, to the physician, whose practice they partner with, and only then to their employer. But what we've found is that causes the lowest abrasion. We've had nurse models, but those nurse models have been mainly in the home because that's where some of the greatest needs are in terms of doing assessments, nursing assessments in the home and things like that. So there are many models out there. We found the greatest bang for buck with a pharmacist-led team because many things can be troubleshooted, like refills on medications, accuracy. And when patients have control of their chronic conditions, whether it's diabetes, whether it's any of these other chronic conditions, they tend to do better and they have greater confidence and they understand when a pharmacist tells them something about their medication, they're more ready to increase their medication adherence and adoption. And when patients take their medications, their conditions are controlled. So it's such a big component. It's an under-recognized component. If you Google, I think, pharmacy and value-based care, there's a nice article by, that was a white paper put out by Deloitte on how much of a need there is. There's actually an oversupply of pharmacists on a national level. We put out 2 jobs for pharmacists. We have 70 applicants. We put out, 2 positions for nurses, and we can't find a single nurse, right? So I think there was a practicality here for us in terms of scaling and adopting a clinical lead within the team that works well with a PCP. In terms of community partnerships, as you all know, healthcare is so local, and so you kind of can't use just sort of a broad swash of resources. You really have to find out who your food banks are, start to work with them, start to partner with them, have far greater local investment into access and resources. And that's where I really applaud the hard work that's often under-recognized by community partners. But local transportation, things like that, and having, I think, a greater confidence within the local environment to support these activities. It can't all be owned by the health system or the practices. So that's where I think partnerships come in.
Yeah, there was a proposed rulemaking by CMS recently, and they've asked for a 90-day comment period on prior authorizations under straight Medicare. Could you comment on that?
No, can you elaborate a little more?
Yeah, I think it
Sorry,
came
I can't even see you with the light. Oh, there you go.
It came from MedPAC as a recommendation to CMS, but there's a 90-day comment period on a proposed rulemaking to initiate prior authorizations on the straight Medicare side. And that's going to change everything on Medicare if, in fact, that goes into place. And I just wondered what your thoughts on that are.
Yeah, I am not a big fan of creating more barriers. So I'd love to go delve back and try to dig that up. One of my clinical partners at UpStream, Dr. Angelo Sinopoli, is on the Physician Technical Advisory Committee, and they obviously track very closely on MedPAC activities. But that's a very arbitrary blanket way of applying utilization management to just create more of a barrier than actually tracking the flow of patients. For us, I think the most important thing is to consolidate the care plan and to bring that back into the PCP realm so that there can be, I think, a closer knit association between specialty care and primary care. as opposed to these kind of abrasion mechanisms, which require more and more prior authorizations and put more and more paperwork in front of PCPs. I don't know, that's just my personal view.
Hi, my question's about palliative care. We're currently working with skilled nursing facilities throughout the state of Florida and have seen results as drastic as reduction in return to hospitals of over 50% in 6 months. Trying to understand how come we haven't seen the shift yet in palliative truly being part of the solution from a primary care perspective.
It's such an important need. And, I've worked for 20 years now with patients with advanced and end-stage heart failure. When I think I first started, even to get patients on, days on hospice, patients were getting onto hospice 4 days before they passed away. And so there's some alarm bell that rings in the community and for patients and their loved ones around palliative care is in some way giving up. Yet patients tend to do better, live longer when they get. So I've started calling it symptoms-controlled medicine. And that way they start to resonate and understand that, they're really having a better recognition and support for their symptoms, the individual symptoms, dry mouth, blurriness, unsteady gait, dizziness when they stand, especially if they're on a diuretic, and start to focus on what helps them feel better. Whether it's some, mechanical manipulation strategy in terms of when you get up, this is what you need to do, to actually, being more aware of your symptoms and starting to call it out. So the other side is that, the opioid crisis, I think, has cast a spell on palliative care. And so we don't seem to have, even wider spread adoption here. So I think there's going to be a lot of work. To me, it's about more integrating that within primary care and being an extension out of primary care. And there are certain disciplines, whether it's behavioral health, even cardiology for that matter, especially on the medical management side and palliative care that need to be part and parcel of, I think, a practice partnership. And so the community partnerships aren't just the non-licensed work, it also is around these key specialties.
That was exactly what I was going to talk about, was palliative care. And that segues to my question. Do you see a need, or do you see out there a trend towards palliative care nurses or palliative care community partners coming into medical groups or primary care practices to do advanced care planning visits and start taking some of those screening visits off of the primary care physician's plate to give them more time to, see the patients, and then having that collaboration of care once the patient is on service, with their community palliative care partners. And so they're helping the architect as like the project manager of the architect. And so you're helping one another, manage the chronic disease symptoms and, get the patient the care that they need. Social determinants, the palliative care organizations, they have case management opportunities to help with, whatever the patients need in the community. So is it just renaming palliative care programs to chronic disease programs? What do you think that would help?
So if we track the payments, firstly, thank you for the question. And, I'm almost scared to ask people to put their hands up in terms of how many primary care providers actually have palliative care, either integrated or in close partnership, because the numbers are very low. At least that's what the data would tell you. So having higher reimbursements for CCM, having advanced care planning payments, I think are helpful, at least in terms of giving palliative care providers opportunities, especially from a care coordination standpoint. The problem is now you've got two sets of people doing this work. And so how do we get this much more integrated? And how does it become, more focused on, less of transactional and much more integrated in terms of an extension of the care team? Data should also help drive those decisions, because if you recognize, whether it's with AI or whether it's with some advanced analytics, this group of patients need early engagement with a palliative care provider or palliative care resource, you can start to have that early engagement being recommended from the PCP as part of a normal routine, part of the care plan is, oh, we have a provider who's much more focused on your symptoms and in terms of, anticipating the future of your own natural illness and how to sort of best, get ahead of that with better planning and better coordination. I think patients would be more open to it. But even there, there are still some challenges. So unfortunately, we'll have to see what kind of digitization of I think that type of data interoperability will actually help, I think, expose this much more to practices. And practices in full risk models tend to want to have a much more integrated approach because the total spend in every hospitalization, I think, hits their bottom line. So I think there's a far greater recognition, and therefore, you hear PCPs talking more about, these types of things. So I think tracking it from the payment will help drive some of these behaviors. Sharing data, predictive analytics, AI, machine learning.
Hello. Very much admire your pharmacist-centric model and embedding with the primary care physician. Excellent. How do you guys make money, though? Aligning outcomes and value-based care, embedding. How do you guys do that?
It's a great question. So in other words, how do you pay for the resources that you're saying that you put in and drive high performance? Let me go to the other side of the spectrum in terms of purely non-licensed folks, because they also do a great job in terms of touch points. But if you have low complexity, that's fine. The moment you have higher complexity of patients and you use, $10 an hour resources, in other words, you're not using advanced clinicians doing some of this work, you just don't see the outcomes. And we saw this, I think, if you look back in sort of the 2008 through 2012, when there was prize money for care coordination, there was tremendous variability in the results. And when you look at some of the more integrated practices that have done well, right here in Florida with like GenMed and Iora, DuPage, they've all had pretty advanced clinically led models that have had, either a nurse or pharmacist or someone at the apex of this. So how much does it cost? You have to think about, some total cost of upwards of $150,000 for such a lead. But when you, balance that out on, full financial risk and savings, then, clearly there's at least an opportunity to build in something like this. So I think it's about driving higher fidelity, higher, clinical outcomes, and having that measurable related to, the metrics related to total cost of care, outcomes, admits per thousand, ED utilization. One last point about this is we don't just have a pharmacist placed without any support, because then their work is not scalable. I've lived in the era of MTM work, and I could never get our pharmacists to take on more than 250 patients, maybe 300, 350 patients, and they would be like totally saturated. But on our model, a pharmacist will have on their sort of direct oversight of approximately 1,000 patients, somewhere between 1,000 and 1,200 patients. They do that because they have concierges working with them as a part of a care team. So there's one nurse, one pharmacist, 4 concierge, 3 concierges that help support that activity. So there's an investment up front, but there's also, I think, key drivers and that they're able to meet and achieve.
Thank you.
Thank you.
Want to thank Justin for taking my question since I have the last one. So I'll narrow the question a little bit. Your open access plan, is that self-sustainable on its own? I'm guessing it led to a decrease in hospitalizations, so shared savings implications, but as a standalone program, was it self-sustainable, or did you have to rely on other aspects of
so I think we can all appreciate it's not for everyone. It's for a limited number of patients who are truly struggling. And we need to remove all potential barriers for that group. So in that particular group, having one less, I think barrier has been an important one by creating an open access forum where they could come in. By even encouraging them to do so, they would call and say, I want to come, but I can't. I don't have the transport. So I think you've been able to then address this in a more proactive way, as opposed to them being a no-show in your clinic, which, by the way, is a huge economic burden to the practice to have patients who were supposed to take an appointment and then don't come. And then eventually, what does the practice do? They actually tell those patients that they can't be seen, right? So there has to be some solution. And to us, to me at least, the most practical thing was, okay, we can't see you in this traditional environment, but you can come and be seen at least, and then we can determine what you need. And so encourage patients to come in when they actually felt well, not when they were totally sick. Because when they were sick, they just activate the emergency department, right? Thank you very much.
Great,
And thank you all. It's a really great opportunity to be here. Such engaging questions, and just made me realize that, this is such a great conference. So thank you.
Thank you,
Nicole.
Sanjay.
Okay.